Wonderful. Our next guest speaker, we're going to see, this is a bit of a novelty. She's here in flesh, which is terrific. We're joined next by Associate Professor Judith Lacey, who is the Head of Supportive Care and Integrative Oncology at the Chris O'Brien Lifehouse Comprehensive Cancer Centre. Chris O'Brien Lifehouse is the most comprehensive integrative oncology service in Australia. Judith, in her role, is committed to innovation, research, education, and has both national and international collaborations. She's very active in the rapidly growing area of medicinal cannabis research and education in cancer care. Please welcome Dr. Judith Lacey. Her presentation today is titled Clinical Practice and the Role of Cannabis in Supportive Cancer Care, Integration of Use in Comprehensive Cancer Care. So welcome. Here we go.
Thank you, and I've got to check out how the technology works, but it's really exciting to be here today and speak about the role of cannabis in supportive care in clinical practice, but also about how we've successfully integrated cannabis prescribing in comprehensive cancer care. And as mentioned, Chris O'Brien Lifehouse is a large standalone comprehensive cancer centre. It's a large research centre, and it was one of the first centres to actually be involved in cannabis research in a government-funded study. And I'm very happy that one of our research projects on GBM was mentioned by Dustin Sulak just now, and so I don't need to talk about that. But what I am going to talk about, and I actually can't read these slides, thank you, is what supportive cancer care is and the common support, and just give an overview of where it sits. I come from a palliative care background and now very involved in supportive cancer care and integrative oncology. And a brief approach to symptoms and the role of medicinal cannabis. I can't cover everything in this short time, but look at my experience and gaps and possibilities for the future. So supportive care in cancer is defined by MASC, the Multinational Association of Supportive Care, is in cancer is the prevention and management of the adverse effects of cancer and its treatment. So this is about managing the physical, the psychological symptoms of cancer, the side effects, and it's from the continuum. It's from the beginning, from the time of diagnosis through to post-treatment care, including rehabilitation, survivorship, secondary cancer prevention, end-of-life care, and also prevention. So alleviating symptoms is very important, reducing and preventing the toxicities of cancer treatment, supporting the communication with our patients, helping their understanding of their disease is actually quite a big part of my role, allowing patients to tolerate their treatment better and to actually get through treatment better, and easing the emotional burden of cancer. And so when I look at a Kaplan-Meier curve like this, and our oncologist will present a curve similar to this, showing the benefit of a new targeted treatment or immunotherapy on cancer treatment, because we know cancer treatments are really improving outcomes for our patients, I see what's happening in all those gaps and how we can support patients who are living longer with cancer and how we keep them living well. I'm also involved in this field called integrative oncology, which I see as seamlessly a part of supportive care, and this is where cannabis seemed to have sit most comfortably in our hospital system and our department, and I'm still one of the only prescribers actually in our area of medicinal cannabis, which is a bit of a load. Integrative oncology is this patient-centred, evidence-informed field of cancer care, utilising mind-body therapies, natural products, and lifestyle modification for different traditions. And this is alongside, it's not instead of, it's not alternative medicine, it's complementary medicine. The aim is to optimise health, quality of life, clinical outcomes, but also to empower the patient. And it's the empowering the patient that is really important when we're talking about self-titration of cannabis and how cannabis fits comfortably into supporting people living with cancer. And medicinal cannabis, I see, and I think many of us will see, is part of caring for the whole person with cancer. And it's the table on the side is actually thanks to a yoga therapist that I work with in my role in Society of Integrative Oncology, just highlighting the complexity of a cancer experience for patients. It doesn't just affect people physically, it affects them, their mind, their body and the spirit. And we use a multidisciplinary approach, but we also need to speak to people and identify what is going on for them and how we keep them well, not just with an absence of disease. And the World Health Organization definition of wellness is there. In cancer patients, we see people presenting with multiple symptoms at the same time, and we call these symptom clusters. And so, for example, patients will have pain, nausea, hot flushes, xerostomia, which is dry mouth, poor sleep, and these will occur at the same time to different degrees, and you need to, and we use patient-reported outcome measures to identify what's going on for the person in order to target treatment, reduce polypharmacy, improve outcomes for the patient. When we're managing patients with cancer, you also have to really understand what is going on for the patient and what their goals of care are, what the stage of their disease is, what the current treatments are for the patient, because and what the goals of care, not just for the patient, but also their clinical team and their clinician. I'm in a big comprehensive cancer centre. We have a lot of phase 1 trials and phase 2 trials. It's really important to understand, are these people candidates for a clinical trial? Are they on a clinical trial? What are their goals, and what are the goals when the doctors are referring, and they refer a lot, the oncologists refer a lot for me to prescribe medicinal cannabis and to help with symptom management, what their goals are and what the patient's goals are, and are they the same? So when I'm prescribing, it's about improving symptom management so the patient doesn't just exist with cancer and exist longer or survive longer, but they actually are thriving and they're living well. And I think I'm very passionate about reducing polypharmacy. There's a lot of polypharmacy in cancer. There's a lot of polypharmacy in palliative care. I'm a palliative care physician for over 20 years now. There's a lot of polypharmacy. I write for the Oxford textbook of palliative medicine on the last days of life. I know how to do polypharmacy. It's reducing that because people are living longer, they have to live well. And I think the beautiful presentation by Dustin earlier showing the reduction in benzodiazepines in the non-cancer space and the reduction of opioids in that space is very relevant to cancer. We have to engage the patient in strategies to enhance their well-being. So it's engagement, and I think self-titration, self-monitoring and self-reflection on what's going on for patients is a part of self-efficacy and self-empowerment, which is very critical in integrative oncology and supportive care. And we have to develop a therapeutic relationship. I'm just not a prescriber. I'm not there to be their weed dealer. And I think that's really important, that prescribers of medicinal cannabis are not seeing a patient once, giving them scripts, oh yeah, you've got cancer, tick, tick, I'll see you in 3 months, go get this from your pharmacy. I see them regularly. I need to follow them up because it's more than just the cannabis. It enables them to do their exercise program. It enables people to eat well, to engage better with their family, to reduce their other drugs. And cancer it's shifting. So I see it as an enabler. So what about me and my experience? And when I wrote this, I started using the SAS CAP-B system. I just analysed over, and in the process of analysing 412 scripts, I've prescribed for probably about 350 patients. I'm not sure what my number is yet, going through it. I am unfortunately the only person that was willing to prescribe cannabis, but it gave me an understanding and hopefully a platform now to teach others to prescribe as well. The TGA changed its system to a category system and almost pushed us all to become authorised prescribers. I'm not, I am an authorised prescriber. It does mean that I have to be very careful and work out ways to collect that data and the justification of why I'm prescribing, because that's for my own self-reflection and my own ability to reflect on my own prescribing. I work very closely with the pharmacy department, and we have a good research program. So when I see a patient, I take a comprehensive assessment. I spend an hour with the patient. I was chatting to Gull Hertzberg over here, and we said, yeah, we spend an hour with our patients. You have to spend an hour with your patient. This is important. comprehensive assessment of the current health condition, full symptom review. We've introduced electronic patient-reported outcome measures. I've been running that as well. I'm a bit tired, but it means that you capture people's symptoms before they come into your room, and we provide that patient-centered strategy, looking at the biopsychosocial model of care. And I have a very fantastic team of over 20 practitioners, and we have a large toolbox, and it's understanding how to integrate medicinal cannabis as part of that treatment regime. And so when I see somebody, do they need a referral to exercise physiology? Well, the answer is yes, everyone should have a personalised exercise program. Yoga and yoga therapy, can that best meet their needs? Where does medicinal cannabis sit in? Would they benefit from acupuncture? Very interesting, what's the role of the acupuncture and these treatments on the endocannabinoid system? We will find out. Is there a role for health coaching? Are they taking other herbs and supplements? What are the drug-drug interactions, herb-drug interactions? And so it is a big toolbox, and medicinal cannabis, I think, is one of the best drugs I have ever prescribed, or products I've ever just prescribed in comprehensive cancer care in my 20 years, but I want to do it well and I want to do it properly. And so we looked at why people present to us, and this is just a snapshot study that we did of 404 patients and what symptoms they were commonly presenting with to our service. Obviously, it's to our service and what symptom clusters we commonly seem to inform our practice and how we streamline my medicinal cannabis prescribing, but also streamline other therapies that we're providing. And you can see at the top of the list, and it's sleep disturbance, fatigue, memory disturbance, reduced appetite, pain, really high up there, and that these occur in clusters, and they occur where they may be mild, but quite a significant have moderate to severe symptoms. The work of Barlev, Schleider and others that was published a couple of years ago and presented at ASCO at a 2019 meeting was highlighted the potential role of cannabis in treating these symptom clusters and treating these symptoms for sleep problems, fatigue, anxiety and depression, nausea and vomiting. So you can see there's a similarity. The patients that I'm seeing could potentially respond well to cannabis. This paper by Kleckner et al., also from a couple of years ago, showed the potential benefit of cannabis, and there is a need for more research, and there is a need for more robust research in this space, and prospective, retrospective, randomized controlled trials, observational trials to see if we're using the right products for the right patients. And I will say that I'm very naive, and I'm still learning, and I'm learning as your industry is learning, and I'm learning how better to choose the right product for the right condition for my patients. So this is where, thanks to a student that was working with me just the other day, I managed to, and thanks to the TGA and the Freedom of Information Act and the SAS Cat B system for enabling me to easily pull my data and evaluate it, which I'm in the process of doing now. You can see that I prescribed the majority of my patients were from this broad group of cancer, pain and symptom management. And it's really, that's a broad button. And so I have teased out what that means, and going through my, through all my patient records to tease out what that means for each patient, what cancer, pain and symptom management I'm talking about. Anorexia and chronic pain in cancer patients. There are 3 non-malignant patients that I've prescribed for with really advanced movement disorders, and who continue on cannabis with Parkinson's disease. But as you can see, it's important to look at the system. When I first prescribed, it took 21 days for an approval. Now it was, and by the end, at the end of September, it was same-day approval, before I became an authorised prescriber, which I don't know if I needed, because it was same-day approval and it didn't really take much time. I think people saw my name and just went, okay. What I need and what I think we need in comprehensive cancer care, and why we have integrated so well, is a superb relationship with pharmacy. And our pharmacist, this is Jeffrey, who I've now got to do his first study in cannabis and cannabis prescribing, together with our partners at the University of Sydney Pharmacy Department. So he is a superb pharmacist, but he also is the pharmacist involved in all the clinical trials, and I'm on the ACRE New South Wales CARE study. It's a cannabis study for refractory symptoms and advanced cancer, and he's involved in that as well. He's meticulous, and you need somebody like that. And so he's dispensed over 790 cannabis scripts for me when we did a quick look at our data. It's important to have that relationship with the pharmacist, and I'm really looking at how I work with our pharmacists to actually help them in the education of our patients, because that is a really essential role in working with pharmacy. I can't do it all, and I can't do it well enough. And patients will come back, and often they'll just stay on the lowest dose until they see me again without that self-titration. Self-titration is a really important part of this process. Pulling the data, I could see what I'm mainly prescribing, and in cancer care and supportive care, I found it easiest initially to just go with a full spectrum one-to-one product, and as I learn more, I can be more nuanced, and I'm finding some other products far more interesting, and I'm always interested in learning but not interested in being harassed. But it is about understanding and learning what's the right product, what's the right dosage for that person. It's not about the diagnosis, it's about the person, the right balance, the right timing, and that's where those studies of PK and our patients are really important. And as you can see, this is just a list of some of the patients that I've prescribed for, and the examples of, you know, a woman who changed her life with aromatase inhibitor-induced arthralgia, was able to actually thrive rather than just, you know, non-thriving from side effects of hormone treatment for cancer. So I thought I'd just throw in a few cases to give you a sense of the patient population. So this is TA. She is a 44-year-old woman diagnosed with a very large pancreatic mass with secondaries to her liver. Adenocarcinoma of the pancreas, moderately well differentiated. She started chemotherapy with 5-FU and oxaliplatin and irinotecan. And she was referred to me by her medical oncologist with quite marked nausea and loss of appetite. She had complex pain from celiac plexus involvement. She had a bulky pancreatic mass. The pain radiated through to her back, round to her sides. You often see people with pancreatic disease and celiac plexus often getting lower abdominal referral of their pain. It's a mixed complex neuropathic pain. She had poor sleep. A lot of anxiety. She's 44, she was fit, she was a bit of a gym junkie, and here she was with a metastatic pancreatic cancer and told the chance of living is only a few months. And she had quite significant neuropathy very soon from her oxaliplatin, which we know commonly causes neuropathy. And she was referred, can I help her with medicinal cannabis to get through her treatment? She's really trialled everything. And this is common. This is one example of the majority of my patients. As I said, I have got a background in palliative care, so I'm supposed to sit comfortably with those patients. They're complex. So here is somebody with not only chemotherapy-induced toxicities of fatigue, nausea, loss of appetite, peripheral neuropathy, but also cancer-related because symptoms and chemotherapy-related symptoms. So when I see somebody who's on chemotherapy, I think, is this caused by the chemotherapy? Is it caused by being on chemotherapy? The anxiety, the sleep disturbance, the difficulty coping, the depression, which 44, horrible cancer, definitely the disease itself, pancreatic cancer, is quite symptomatic. And as we know, people aren't just on chemotherapy now. She's now on a targeted agent as well as chemotherapy. She's still alive, still taking cannabis. But the impact for her was that with cannabis on quite a low dose of 1-to-1 THC, CBD, a TDS 3 times a day regime, she was able to get through her treatment without dose reduction, managing her chemotherapy-induced nausea and vomiting, improving her sleep. And as her chemotherapy has been changed, she stayed on cannabis because the improvement in her sleep and her appetite was so profound that I continued to prescribe it, and it has improved then her fatigue and her ability to interact and to exercise back at work, in the gym, doing quite well. We hope. There's no wood there, that's like Perspex. But anyway, So as you can see, you need to know, in order to prescribe cannabis for patients in the supportive care space, we really need to look at educating people that are in knowledge about the cancer, the tumour itself, the cancer treatments themselves, what are the common toxicities, how best to manage symptoms, because it's about other ways of managing these symptoms, not just first-line cannabis, but actually we're talking about refractory symptoms, and I'll talk a little bit more about that. And the big challenge for me is that my toolbox has expanded, but I need to know everything about that toolbox, and I need to learn more about the cannabis products that are becoming available, what to prescribe to what patients and when. And so, as I mentioned, there are common symptoms that our patients will be experienced during treatment. And so this is another person, a 44-year-old woman. I am going to speak, she's pretty public. She's on the ABC Catalyst did a story about her, but they cut out the bit about cannabis, but she's a pretty remarkable human being. She was diagnosed with stage 4 cancer of the cervix, locally advanced disease with bulky intra-abdominal retroperitoneal lymphadenopathy, which is not very nice for pain, anxiety, sleep disturbance, a mother of 2 kids under the age of 6, and she was somebody who received a Platin and a taxane as part of her treatment, had as well as bevacizumab, Avastin, which caused her hypertension, and she developed severe arthralgia, nausea, insomnia, and honestly, I think she ticked every box for every side effect you could possibly get with chemotherapy on her first dose. So she was classic of someone who had symptom clusters that can respond to cannabis and reduce, and I really wanted to reduce polypharmacy. So she was put on benzodiazepines, multiple anti-nauseants, quite a few different opioids. We tried tapentadol, which worked partially. Endone didn't help. She had low platelets related to her treatment, so non-steroidals were out. We didn't want her to, she was on dexamethasone that made her very agitated, but she needed it for her nausea. And so we started, so this was someone who started, we started a CBD one-to-one cannabis product, broad spectrum. She's only taking a very small dose, and that managed to get her through her treatment without dose reduction, improving, again, her sleep, which she said, oh my God, if I can sleep, I can function, I can get the kids to school. It got her, she used it 3 times a day, only the day before and up to 5 days after her chemotherapy. The rest of the time she just used it afternoon and evening so that she could get the kids to school. She was very sensitive to it, only used a very small dose, like 0.2, 0.3 mils. Don't need large doses. I find my patients don't like feeling stoned. They don't need to feel stoned. They want to feel, and getting her to exercise, get rid of her walking stick, keep moving and thriving. Getting her through treatment was the priority, which she has managed to get through to now. So I mentioned chemotherapy-induced nausea and vomiting quite a bit because I guess it really is one of those common symptoms that cannabinoids were first looked at. The studies in HIV were very much looked at nausea in patient populations, and there's a Cochrane review, and there was a need to do more research in this space, but it affects about 80% of patients receiving chemotherapy. It's usually poorly managed. If it's poorly managed, it can result in dose reductions of chemotherapy, which can impact on outcomes. It can impact on nutrition, dehydration, and as a result, people can't really function as well. So it was a priority in our hospital to really be engaged in improving chemotherapy-induced nausea and vomiting. And it's not a simple, there are actually 5 types of chemo-induced nausea and vomiting. There's acute, delayed, breakthrough, anticipatory, like those people that walk into the hospital and they're already vomiting before they come in because of that anxiety component. Commonly in breast cancer, they're given benzodiazepines as part of their regime. But anyway, I just don't like that practice, sorry. And refractory symptoms were what I focused on and we focused on initially. The drugs have improved significantly with 5-HT3 receptors, NK1 antagonist, olanzapine, which is an atypical antipsychotic that's been shown to improve chemo-induced nausea and vomiting, dexamethasone and dopamine antagonists, and as well, of course, then cannabinoids. And so at our hospital, Peter Grimmerson, and you can see many other names that you may recognise in this study, was the first New South Wales funded, government-funded study for cannabis in cancer, for medicinal cannabis in chemo-induced nausea and vomiting. Peter Grimmerson is one of our medical oncologists, and we work very closely together, and showed that this was a pilot randomised crossover trial of two multi-site phase 2, 81 participants, 72 completed it, improved chemo-induced cannabis, a one-to-one product, which was extracts, improved chemo-induced nausea and vomiting in up to 25% of patients. 83% of patients preferred it. They were blinded and continued to tolerate that, and as a result, it has really changed the way we approach chemo-induced nausea and vomiting in our centre and hopefully in other cancer centres around the world. And so I thought I would just finish with the, just continue, or near the end of my talk actually, but talk about prescribing and monitoring and the impact research has had on prescribing cannabis in a large comprehensive cancer centre. I prescribe on the wards. We are a very large centre for youth and adolescents in cancer. This is a 19-year-old girl who was referred to me in desperation on the ward. She had a very large, a young, observant Muslim woman, very conservative, not thriving. Poor girl, had this huge nasopharyngeal cancer diagnosed. She's alive, she's doing well, she's back at uni. So that's the end of the story. So I'll jump in there. So don't worry. But she was diagnosed with this very large cancer, and the treatment for this is concurrent chemotherapy and radiotherapy, a very hard treatment. She had a PEG tube inserted, so she couldn't eat or drink with the treatment. The toxicity was very, very hard. She couldn't leave the hospital. She came in, she couldn't leave. She was in a dark room. She had intractable nausea. She wasn't functioning. They tried everything. She was on every medication that was listed on that list, plus more. The psychiatrist in there, oh my God, she's just not coping. What can we do for her? And so the oncologist and the radiation oncologist and the head and neck team said, Judith, please. And so I went to start seeing her, and the first thing was, of course, get rid of the medications that aren't working. So rationalising her medications, comprehensive assessment, sit with her and her family for the hour. Look at non-pharmacological management. We have acupuncture, reflexology, meditation. We brought it all up to the ward and started looking at reducing her anxiety and improving her outcomes, see how we could. And then we talked about cannabis oil. Now, dietitians don't like anything going down PEG tubes. Just so you know, they really don't, because it can leave it, and particularly cannabis oil, it leaves a bit of a residue. But she couldn't tolerate, all I had at the time was oil. She couldn't tolerate it under her tongue, it just made her gag. And a lot of my patients are actually saying the taste is too powerful when they've got a lot of nausea. So how do we, I think we're getting there with wafers and other means of delivering it, but they agreed if we mix it up with the feed, we can deliver it with the PEG tube. It's interesting actually that she needed quite a high dose of cannabis. She had no significant side effects. It was on a meal 3 times a day of a 1-to-1 THC CBD that managed to actually get her through her treatment, reduce her nausea so that she could actually sit up, get out of bed, start walking around. We reduced a lot of her other drugs that were just bombing her out, big doses of olanzapine that all they were doing was sedating her without improving her outcomes. But it also enabled us to see the benefit of prescribing on a ward. So here I am just writing on the medication chart the cannabis dose. Self-titration is very difficult on the ward, so it's me going up there and adjusting the dose every couple of days. Cannabis sits in our SA cupboard, and now when people come in, it's there. You know, a lot of our patients are on cannabis on the ward, but it was really important, educate the nurses to feel comfortable with it, have it on the ward, work with the pharmacy, and work with the supportive team. I pinched this from following patients on immunotherapy when it comes to monitoring symptoms with on immunotherapy, because this is how I approach monitoring patients when I prescribe cannabis. It's proactive monitoring, early recognition of any side effects, reducing polypharmacy, appropriate vigilant follow-up. When she finished treatment, we stopped cannabis. She went back to nursing school. She's doing fantastically, and her cancer has not recurred, and she managed to get through her entire treatment. There was no way she was going to get through treatment without that. But this monitoring and being vigilant is really essential. I'm being watched. It is, I prescribe, I see it as essential to good cancer care, but you need to do it well, and it's good medicine, so practice medicine well. And finally, what about the gaps? So we're very fortunate to be a big centre and have a lot of students from different universities. We had a student from Western Sydney University, and together we do a lot of research in day therapy, and so we looked at health professional attitudes. It's actually hard to get people to say yes. When I say, do you have a spare 8 minutes during COVID, they're actually not saying yes. Put these posters all the way around the hospital. There's a QR code which I've covered up because I don't want anyone to do this form. It's still a live survey. What are your attitudes to medicinal cannabis? Have they changed over the last few years? Where do you see the benefit of prescribing medicinal cannabis? And as those surveys are coming in, we'll be able to analyse. And then what other education would you like? How can we improve your understanding of cannabis? We also asked about other therapies as well, like acupuncture, massage and everything else in this survey. But it's important to embed research into clinical care, and that's what we're trying to do, and I see that really important in the medicinal cannabis and supportive care space, particularly in integrating into a comprehensive cancer service. Observational studies such as the Care New South Wales study is important. It informs prescribing. It's a bit slow to recruit. Retrospective reviews like I'm doing and prospective strategies are really important, and of course the gold standard of randomised controlled trials help us to address the gap. And so in closing, when I give a talk, there's always a long to-do list, and I guess that's what keeps us excited and busy and still working, rather than me taking off in my camper trailer, which I do love. And that's about developing pathways of care and educating others on how to prescribe well, how to do cancer-specific prescribing, learning from industry how we can do it better and what new products and new and exciting things are out there, learning more about these products, and also really looking at the financial toxicity of cancer and financial toxicity of cannabis and how we can address this, and so that more patients do have access. And that's our next study. Thank you.